In this short review, we're going to go through and talk about how pulmonary disease is diagnosed. Now, this is meant to be a review for someone who's already studied this thoroughly. We're just going to hit the highlights and use this as a refresher. If we think about all the different types of pulmonary diseases, these are the things we might see in our patients who present to physical therapy. These might be the medical diagnoses that we see. And of course, these medical diagnoses will lead to different functional impairments or activity limitations and will affect movement in different ways. But these are the diagnoses we'll see in the person's medical diagnosis. What are some of the major signs and symptoms? Well, cough. So is the person coughing? How much? What's the production like? Is there a color to it? Is there a smell to it? Dyspnea. What is their shortness of breath? Do they have shortness of breath at rest, during exertion? Has it gotten worse? Has it gotten better? What time of day is it better? Chest pain. Are they experiencing any chest pain? Now, we typically think chest pain and MI or heart attack, but we also have chest pain with pulmonary disease, pain that might increase with deep breathing, pain that might increase with coughing. Cyanosis, looking at the person's fingertips, looking at their mucous membranes in their mouth. Are there any color changes? Are we seeing them turn a shade of blue that might indicate problems with oxygenation? Clubbing, if we look at their fingernail bed, so we look at someone's fingernail bed and we see it has a round shape to the edge or a swollen shape to the tip of the finger, that can indicate that the person has problems with getting oxygen out to their distal extremities. And then breathing pattern. We might think of normal breathing as diaphragmatic breathing, shouldn't be very stressful at rest, but our patients come to us, they might have a barrel chest, they might be very much using their chest to breathe, and they may be struggling to breathe at rest or during very basic activities. So these are the major signs and symptoms that might indicate that the patient has pulmonary disease. As you look at this list, you might say, well, this could cross over to other diseases, other classifications of things going on. That's exactly true. These are just some of the signs and symptoms. It doesn't mean for certain they have pulmonary disease. But this is where some of these special tests come in. A pulmonary function test, there is the forced vital capacity where the person blows as fast and hard as they can for 6 seconds, and they should be getting most of that air out in the first second or so, about 70 to 80% they should be getting out. We have arterial blood gases, and with arterial blood gases, we are looking at the acid to base, or the pH of the blood, and that can tell us how well someone is taking air in, how well they're getting the carbon dioxide out. A chest x-ray or chest radiograph can give a lot of insight into what the lungs look like. If there's sputum in the lungs, if there's air trappings, if there's consolidation, what does the diaphragm look at? Like, are the lungs hyperinflated? We can pick this up from a chest radiograph. And then sputum analysis. They can collect sputum, getting sent to the lab to determine, is there some sort of infection? Is it viral? Is it bacterial? What's going on? A person who has lung disease, they may be classified in various ways from acute versus chronic. So someone who just has a infection in their lungs, but before that they were healthy, they may have acute lung disease, versus long-standing chronic disease. We'll talk a little bit about obstructive and restrictive in the next slides, and these two classifications we're not going to talk too much about, but there's things you've probably had previously in class. Obstructive versus restrictive. The big difference is flow and volume. So the way I think about obstructive, as you see, I have airflow bolded. So obstruction is a problem with flow. There's something limiting the air from getting out of the lungs. Typically, I know it says trouble getting air in and out, but really the problem is getting the air out of the lungs is where the issue is at. But because the lungs are so filled up with air, the person can't get them all out. When they take their next breath in, there's not very much room in the lungs left to get that new fresh air in. That's something called dynamic hyperinflation, and we'll talk about that a little bit later. Now we think about restrictive disease. This is a problem with lung volumes, trouble getting the air, or a certain amount of air in and a certain amount of air out, in a sense, because you can only bring so much air in. In theory, the flow is the same. No problem in the rate of getting the air in. It's just the volume of air. But just like many things in healthcare and medicine, life is not black and white. So the thing to point out is that while we put these different lung diseases in different categories, honestly, they cross over. There's a little bit of obstructive and restrictive in every disease, and we'll jump into that a little bit more. This is a nice chart that shows you the difference in lung volumes. If you're a visual learner, you can see that normal is tidal volume right here, and tidal volume is pretty much the same. This is the air that we bring in and out at rest. It stays the same. The big thing you see with obstructive disease is that the residual volume goes up. So there's more air trappings. The person's not getting all the air out. And then restrictive disease, the big thing that we see is the volume is down. So everything is shrunk down, leading to a decrease overall total lung capacity. This is that forced vital capacity test that I mentioned before. So a person takes a deep breath in, they blow, 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 blow as fast as they can to get all the air out, typically over 6 seconds. Most of the air should come out in the first second, the FEV1, or forced expiratory volume, in 1 second. That's typically about 70 to 80% of the air, or if you think about FEV1 over FVC, that should equal about 70 to 80%. FVC is forced vital capacity, and we won't worry too much about these right now. And then based on the pulmonary function test of the forced vital capacity, the disease can be classified at different stages of obstructive disease. And again, this is the classification for obstructive disease. And restrictive disease can also be classified on the severity and the changes in lung volume. But these are for obstructive disease, the GOLD guidelines. And I know it says 2006 there, but this classification scheme is still the same now in 2015. So, to review, obstructive disease is again a problem with flow, how well we get the air in and out. Restrictive is volume. So if we apply that to the forced vital capacity test that we mentioned before, a normal would look like this, let's say, and this is 1 second right here, and this is 6 down here. How would obstructive disease work? Well, remember, it's a problem with flow, not necessarily volume. So what happened, it would take longer to get the air out, and we'd probably get near or close to the same. But that ratio of FEV1 over FVC is less. So the same air comes out in theory, it just takes longer to get there. Whereas we think about restrictive disease, what we're going to find is the flow is pretty much the same, but the volume is lower. Okay, so there's that variation between obstructive and restrictive disease. So in review, if we think about first the patient might present with signs and symptoms, and then they hopefully go to their physician or healthcare provider, and we have special tests done. And remember, those are going to be the forced vital capacity test, arterial blood gases, chest radiograph, maybe sputum analysis. There might be some differential diagnosis done with cardiac issues or something else going on, but the special tests are done, leading to a diagnosis and a range of different diagnoses, but the categories might be more obstructive disease versus restrictive disease. And then from there, the severity would be classified based on some of the pulmonary function tests and the symptoms. And then from there, certain treatments would be carried out, and we'll talk about that in a future recording. Hopefully this helps you remember some of the information about classification and diagnosis of pulmonary diseases.